Now let's shift to the renal vessels, starting off with the renal arteries. And the main reason we get asked to look at the renal arteries is for stenosis in patients with refractory hypertension. The diagnosis can be based on either direct or indirect criteria. For the indirect criteria, you interrogate the segmental arteries and look for absent early systolic peaks and tardus parvus waveforms. The direct criteria require accurate angle-corrected velocity measurements in the main renal artery of at least 200 centimeters per second. There are a wide variety of criteria here as well, or as we use in our lab, a renal artery to aortic peak systolic velocity ratio of 3.5 to 1 or greater. It's important, however, to look distally, especially in younger patients who may have fibromuscular dysplasia, which tends to involve the distal vessel. Whereas in the older population with atherosclerotic narrowing, the stenosis is usually very close to the ostium. To get the ratio that I talked about, of course, you have to measure the velocity in the proximal aorta, as is shown here, in this case at a peak systolic velocity of 0.8 meters per second, and that's the basis for the ratio measurement later on. This is one of the first things we do in the renal artery Doppler sonogram. But then, of course, we go on to look at the vessels indirectly and directly. In this case, within the kidney, looking at the intraarterial waveforms. These are normal with sharp upstrokes. We also pay some attention to the resistive index, although an increase in the resistive index tends to be nonspecific. And, of course, we look at the main renal arteries. Doing that can be technically very challenging, especially in large patients. It's facilitated by having the patients fast overnight to reduce bowel gas, but it can still be very difficult to do. In this case, we have an abnormal intrarenal waveform, in this case the middle of the kidney showing a tardus parvus waveform in this patient with renal artery stenosis further proximally, and in the same patient interrogating the main renal artery showing very high velocity flow with aliasing due to stenosis. We sometimes get asked to look at the renal veins for thrombosis as well, although we have an adult patient population at our institution, and this is a more common diagnosis in children than adults, and can be associated with various conditions, including dehydration, nephrotic syndrome, hypercoagulable states. Those are some of the predisposing factors. And more commonly, we see renal vein thrombosis related to renal tumors, primarily renal cell carcinoma, with associated with tumor thrombus. Here's one such case, a clip showing this kidney with a large mass in the anterior part of the kidney, and in this other clip showing the right renal vein, which is distended with tumor thrombus. More on that in a little bit. There's also an incidental gallstone. Next, I want to talk to you a little bit, very quickly, about the mesenteric vessels. There are a variety of indications for looking at the mesenteric vessels, the arteries, primarily with ultrasound, including bruits, suspected aneurysms, and most commonly suspected mesenteric insufficiency. This, like the renal sonogram, is best done with the patient fasting and early in the day. It's important to examine all the vessels as best you can, the celiac axis and its branches, the SMA and the IMA. And I won't go into this in great detail, just to mention that various thresholds have been published. These are the ones that I use in the celiac axis and the IMA, 200 centimeters per second, and the SMA, 275 centimeters per second. Here's an example of an abnormal case of celiac axis with a peak systolic velocity of greater than 4 meters per second, in this case with celiac axis stenosis. I want to close by talking about the IVC. The hepatic segment of the IVC is easiest to see, and in fact, looking at the IVC is part of every normal abdominal sonogram. Even if Doppler isn't being performed, you have to look at the IVC structurally. The waveforms within are variable, but usually similar to the hepatic veins to monophasic. And as I mentioned, you can get tumor thrombus in patients with renal cell carcinoma, or you can get bland thrombus in other conditions. And this, in fact, is the same patient that I showed you earlier with the IVC and right renal vein thrombus related to a large renal cell carcinoma. In this case, the IVC is distended with echogenic thrombus. And one trick that I found useful in showing that this is tumor thrombus and not bland thrombus is not to use color or power Doppler, because I think that can be very difficult and you can see a lot of artifact and spurious signals, and you really want to know that you're looking at a pulsatile signal. So what I do is I put the spectral Doppler cursor with a very large sample volume or sample gate on the thrombus, as I've done here. In this case, I've shown a low resistance arterial pattern related to neovascularity in this tumor thrombus. We can occasionally see thrombus in the IVC from other causes, whether it is propagation from below in patients with lower extremity DVT, or, as in this case, thrombus in the IVC related to a filter, as is shown in this color Doppler image. So to summarize, I'd like to reiterate 2 points. One is to pay close attention to angle correction. As I've said before, if you are incorrect in your correction, as it were, you will get incorrect velocity measurements, and that can lead to incorrect diagnoses. And second, to use grayscale and Doppler, color, and spectral imaging in concert in making your diagnoses. Thank you very much.